I'm Peter Block at ACC 2019 in New Orleans. With me is Ian Cronish from Columbia in New York, and Ian has another trial concerning the whole issue of depression in patients, this time patients with acute coronary syndromes. So Ian, let's quickly talk about the trial, which isn't quite as outcome happy as we'd like, but there's a very important issue here that we need to talk about. So quickly about the trial, CODIACS-QoL.
Yep.
There you go, CODIAC-QoL. Tell me about the trial, tell me about the outcomes, and let's talk about depression.
Sure, I can get through the trial pretty quickly. Basically, this trial was to test whether systematically screening all ACS patients for depression could help improve quality of life or depressive symptoms across the entire group, both those who screen positive and those who are screen negative. And it was actually a negative trial. We didn't find that this approach to systematically screening all patients, calling them on the phone after ACS and screening them with a depression instrument actually helped improve the overall depressive symptoms of the population. But we really don't want clinicians or patients to walk away thinking that depression is important. Certainly depression is a major risk factor.
Well, let's talk about that a little bit, because the trial is about ACS patients, and maybe they're not as high percentage depressed patients as long-term heart failure patients and other. But cardiologists, when they see patients in the office, have to start remembering this issue of depression. So let's talk a little bit about that. What does your trial tell us about the number of patients and so forth, and how do we sort of attack this?
Sure. So one thing I should really clarify about the trial is that we specifically excluded patients who had a history of depression, and we only found 7% of people had sort of newly identified depression after ACS.
That's still not a minor number.
That's still not a small number, but certainly patients who have a history of depression, cardiologists should be very mindful that the depressive symptoms may be undertreated or may be recurred in the ACS context. And like I say, we know that patients who have depression have increased risk of not adhering to their medical treatments, and they have higher risk of recurrent cardiovascular events. So really, this is still an important issue that cardiologists should have on their mind when they're seeing their patients.
And in fact, I think we need to ask our patients, if we do think they're depressed or they talk about their depression, get them help.
That's right. A lot of these patients I'm a general internist. A lot of these patients are co-managed by general internists or family doctors. And certainly it's good for cardiologists to have psychologists or psychiatrists that they know that they can refer their patients to, because oftentimes sort of co-managing these patients might be the best approach.
Okay, so for everybody out there, this is a negative trial, but a positive concept, right? We need to think about patients that have depression if they raise that issue to us or if we think they have it. And for God's sakes, let's get them treated and help them, because in fact, we think that treatment really will keep them from dying. Depression kills, right?
We definitely agree with that message.
There you go.